Bon dia to everyone attending this not-so-mini symposium on family-centered care in the times of COVID. Danke for the opportunity to share some new findings about the impact of COVID-19 related hospital restrictions on patients in family-centered care. It's hard to believe how much the world has changed since my wonderful first visit to your beautiful island this time last year. I miss you, Curacao. Before I begin my remarks, I'd like to thank the fantastic team who worked with me to complete the rapid research that I'll share with you today. It was a true collaborative effort with contributions from the Institute for Patient and Family-Centered Care, University of California, San Francisco, and University of Washington colleagues, and supported by the UCSF Preterm Birth Initiative communication team. Special thanks to everyone. Now, the COVID-19 pandemic has caused much direct suffering. It has also resulted in disruption of the global economy and a chain reaction of adverse effects, particularly for more vulnerable populations. It's easy to get discouraged by the enormity of the devastation caused by the virus. However, there are things we can do, and we must not give up hard-won progress in humane, science-based ways of delivering healthcare. That is family-centered care. In fact, we should instead be doubling down on what we know works. This will be the focus of my remarks today. Concerns about hospital provision of family-centered care during a global crisis are not new. In Liz Crocker and Bev Johnson's book, Privileged Presence, they describe the negative impacts of the 2002 to 2004 SARS epidemic on family-centered care, cautioning that we must pay attention to the side effects of separation of families from patients. The Institute also published a white paper with lessons learned from the SARS epidemic and outlining steps that healthcare organizations should take in planning for a pandemic. They advise that it's important to take steps to contain the illness and to remember that family members are stewards of patient safety and integral to a patient's well-being. However, not everyone has listened. For example, when the COVID-19 surge hit the US, hospitals such as a major New York academic medical center closed their doors to all family and support persons in the name of safety. In this instance, a national outcry followed on social media and in the press. And about 2 weeks later, the New York governor instituted a reversal of policy. A month later, WHO clarified their guidance specific to newborn care, and other groups such as the American Academy of Pediatrics followed. But concerns about overly restrictive hospital policies have persisted, such as in a recent news story from Texas. I encourage you to watch this brief interview with a mother whose newborn was taken from her because she and he tested positive for COVID-19, even though neither experienced any symptoms. Their 20-day separation is not in line with current recommendations and is harmful to the baby, mother, family, community, and the healthcare system. This is the collateral damage of COVID-19, and it's something we can and should do something about. But it's hard to combat misinformation or promote best practices when there is so little information available about what is happening on the front lines. So my colleagues and I quickly designed a survey to gather information about family presence in hospitals and to learn how hospitals were partnering with patients and families in changing and implementing new policies. Our methods were simple: an online survey posted from May 8th through July 31st. We conducted outreach via websites, professional groups, and targeted emails to hospital contacts. Respondents could report on hospital-wide policies and practices or for specific patient care settings or settings. I'd like to share these results with you now so that you can use these findings to prevent further collateral damage to family-centered care in your settings. By the closing date, we'd received 697 responses, of which 541 completed at least 20% of the questions, which is answering for one unit or hospital. These respondents represented 395 unique hospitals and health systems. All respondents reported hospital policy changes regarding family presence. First, I want to show you a snapshot of the hospital-wide results. We asked how many support persons were permitted at a patient's bedside by setting. As you can see, most of the adult settings were not permitting any support persons to accompany patients. The maternity care settings and pediatric settings predominantly permitted one support person with the patient, and some neonatal and pediatric settings permitted 2 support persons. Now let's take a closer look at the selected responses from the neonatal and pediatric settings. Responses for this part of the survey were primarily from North America, with about a quarter from Europe and the UK. Respondents were primarily unit leaders or direct care providers. In this question, we asked how COVID-19 policy changes impacted the 4 domains of patient and family-centered care. You can see that just about 20% of the units reported negative effects of the COVID policies on their ability to provide respectful and dignified care, and a few even reported it was improving. Whereas 40% reported that the policies had negatively affected information sharing. The majority of units reported negative impact on patient and family participation in care planning and on patient and family support related to the hospital's COVID-19 policy changes. There were some small differences in the proportions across pediatric settings, but they may not be significant. We also asked a specific question about the impact of healthcare disparities. And here you can see that 50% of the NICUs and PICUs reported a negative impact. This was in contrast to the general pediatric wards, where respondents more often reported no impact or a slight improvement, although the numbers are small. We asked a series of questions about what had been put in place to support family members during the pandemic. For those family members permitted to be present, most, but by no means all, of the sites provided personal protective equipment. About half or less provided access to free or subsidized meals, transportation, or overnight accommodation. But the numbers of NICUs support providing these services was notably less than the other pediatric settings. So we must ask ourselves and our hospital administrator colleagues why this must be so, when the need for proper nutrition and proximity to the infant is essential for breastfeeding, for example. Notably, mental health services were more often available for NICU infant support persons, but the numbers of sites reporting this was small. For family members who were not permitted or who weren't able to be with their baby, about 60% of reporting sites encouraged the use of technology. About a third offered or encouraged use of specific software apps or provided access to support persons such as family liaisons. Fewer of them loaned devices to families, and a few provided clear guidance on how to keep devices clean. Again, there were some small differences in access to these supports by unit type. Additionally, family members who were not permitted or who weren't able to be with their child were offered the possibility of participating remotely in rounds in about 30% of the NICUs and general pediatric wards and about 50% of the PICUs. 60% of the NICUs and PICUs made daily calls to non-present parents, but fewer sites provided the option of remote family meetings or assisted in helping families with access to video calls with their ill child or partners. And again, mental health services were rarely provided. In summary, this very brief, hot off the press snapshot of our survey of COVID-19 hospital policy impact on family-centered care shows that hospital leaders and providers perceive that family-centered care has been negatively affected. For pediatric units, the impact has been most profound in reducing family support and participation in care planning and in widening disparities in care. We found substantial variability in policy and practice across settings and variable efforts to mitigate the impact of the restrictions. We hope to continue this work and more formally establish a registry for ongoing tracking of COVID-19 hospital policies on patient and family-centered care, and to conduct further surveys, interviews, and analyses to understand the variation in policy and practice, and to work with colleagues, such as everyone at this symposium and online, to share best evidence-based practices and innovations as you discover them. Although these results may not surprise you, they are a call to action. And I hope that you'll visit our website and review these initial results in more detail. We've posted a link to register your hospital or unit to take part in future surveys and interviews. And I hope you will help us share the link widely and help recruit many more pediatric units and hospitals to register and participate. We need representation from the islands, Central and South America in particular. I encourage you to check the site regularly for updates. It's clear that the response to the COVID-19 pandemic so far has been fear-based, creating false choices between the best interests of the population and family-centered care, treating family members as visitors against which staff need to be protected. As the pandemic wears on, we must heed the call to action for a more rational, evidence-based approach where families are seen as allies and partners in caregiving. They're provided with education, support, and PPE, just like staff. They're treated as respected members of the healthcare team who provide essential emotional and physical supports to patients, and recognized for their contributions that they make to patient and staff safety and emotional well-being. As the epidemic evolves, we must update policies to ensure that hospitals and units practice shared decision-making for every aspect of care, and in determining the necessary restrictions, that they increase the support to mitigate stress contagion for families and healthcare professionals, and that hospitals use careful ethical analysis and emerging scientific evidence to weigh the risks and benefits of any family presence limitations. And finally, to consider when the exceptions might be made or when to lift the restrictions altogether. Here are some sites to watch for up-to-date guidance on family-centered care as the pandemic evolves. And I'll close by saying, the world will be watching you, Curacao, as you continue to lead in innovating family-centered care practice in times of COVID and beyond. Mashi Danki.